it shall be possible to share all of the data. So actually here I'm coming and involving you, the first hack, what is a care plan? So I have put in here, a care plan is a shared agreement about goals, actions, and responsibilities over time. So this is some topics. You are invited to add other topics to be discussed, but who is it for? The patients, for the healthcare providers, or for the system? The system here, it could be the government. They are interested. At the moment, they are really interested in the Danish government to see how is it going. Are they actually following the clinical guidelines? From next year, we will have patients' rights for the first 2 chronic diseases. So we have had it for a number of years with cancers. So if you have a diagnosis for a chronic disease, you have a patient right. You should have a care plan within 30 days. You should be offered specific treatments and so on. And they want on high level to follow up. Are the doctors in Denmark actually following this? And what are do we have a healthy population? And of course, they are also looking for some savings. But what problem does a care plan solve? And is it static or is it dynamic? So please, any comments, or put in some comments in Zulip, or
and also a bit of housekeeping before we get there. I think we should join the Teams meeting to have the recording available later as well. I think on the laptop that you're presenting on, it makes sense.
Shall I?
Yeah.
Can you help me?
That's
Specific page.
yeah, it's on the page. Let's see.
This one, can
Several things. No. I'm thinking with more. These guys are looks right. I don't know too much about.
care plan, see details,
There's a small amount of time with
and where
you in sprints. Elaborate. Yeah. Yeah, like this actually the work's going to that. Perfect.
It is on. It is in the agenda of our meeting. Yeah.
patients. This is written over.
Yeah. Yeah.
Where do you have it in? Giorgio, did you find the presentation of Morten in the Excel repository?
What is the extra repository?
The Medcom SharePoint.
SharePoint?
He said that he put it there, so I don't know. Consultation standards. The letters.
Attachments is in the meeting.
No, where he has.
Organization.
I don't know if it's in WP2 or.
It's might be one there.
So,
the very business.
so I guess it's. You need a lot to make that. Oh, yeah. It's one for the. Yes. I love it. I say there. Hopefully, we're going to see there. Should be on the box. So,
I found an issue booth at the Radical Health Festival.
No,
Yeah, so reporting D14. Interview.
if it's showing the screen, that's it. Yeah. Try to reverse that. Yeah. Keep on moving. What does this again? You work on you will get this is the way it's we are going to investigation or this going to their own.
task 2.2.
Yeah.
At least in task point 2.2 was the working group meeting.
Some of the burgers.
Did you manage to do it? Okay. So where in the Metcom SharePoint did you add this presentation then? Because I cannot find, I found the
Yeah, we wanted to. Oh, because I will shoot. This is. You have to drag it over. Yeah, but sure. Not an expert in that. Maybe could you just share the window? I've shared the window. I think there's. No, we are. But of course, sitting out this, even the survey, very marvelous. Yeah. So, yeah, it's not going to go it's the service. It's going to be this, you sit your hearts, all the songs. The action thing, yeah, the jump me. Snake, I think I'm yours. Yeah, and it's just, that's just probably. So this needed. And it's also, I'm definitely honest. It's whatever that is, just if we get into the yeah, something a lot of rates. Actually, understood the cases, but we haven't seen so it's a severe time for the listening is only when the children. I guess the comments all the goals that we made to wait to the fire with yeah, so yeah, fire, yeah, so exactly. Yeah, it's 1 hour 5 6. That's what I was thinking. And then you can find it lots of you got to be more than once. There's a lot of seeing yeah, challenge anything new with that project there as well as okay, I mean, that's just always okay, now it's perfect. Let's not change it. You can just get your. It's not burn.
Yeah, sorry for the delay. I yes.
Can you see, do we have any connected to the Teams meeting from outside?
Nobody.
There's at least somebody called Arno, so I would
Okay,
take that as a yes.
okay.
Oh, there is
continue.
one.
But now we are on Teams and we are doing recording. So I saw a few hands before. Gotcha.
This only for a single provider, demands 18 members. Because most of the time, current decisions are managed by a team of clinicians. For example, in our case in Turkey, GP creates a care plan, but it can be shared with the specialists like the cardiologists, the internal medicine practitioners, and we also share the care plan with the patient. They can see their plan. And in several leading projects, we have created systems for patients as well, so that they can follow their care plan. They can be reminded about their activities, their medications, or maybe sub-measurement activities. So it is it's a joint system that needs to be done.
Yeah, Giorgio.
I think that there are different, depend of the scope of the care plan. In the sense that I can imagine you may have different instances of the care plan. For example, if you have a set of recommendations for a patient, or what you should do because you have that kind of condition, or because of your history, that is more patient-oriented. If there are instructions because you need to perform specific action for a patient that is at home, and then you need to keep track of what you are doing for that patient at home, then is more healthcare provider oriented. So it depends on the purpose of the care plan. So I do not expect to see a single that fit for all.
At the moment in Denmark, it is the family doctor who are responsible for doing the update. We have discussed, can other health professionals from the hospital, from the municipality go in and update? And who is then having the responsibility for the data and the treatment? But I will show when we're coming to the architecture that their input, digital input to the care plan, has to be provided. Yes.
Okay, so do I understand correctly that it's the clinician who kind of writes the care plan? He kind of gets to decide how this patient is to be treated, and what is the kind of interface between care plans and clinical decision support? Wondering where is that interface?
Yeah.
Says we're creating clinical guidelines. So we create several modular CDS services that has the clinician to serious clinical guidelines. For example, it reminds whenever it's necessary to refer the patient to a specialist. So whenever we have follow-up, we want to arrange to go with different tone patient to patient. For a high-risk patient, to follow up would be every 3 months, but for a regular patient with low cardiovascular risk, it could be every 2 years. So it just presents the patient's information and it goes easily from healthcare records, runs CPS service, which kind of automates the guideline and presents the recommendations and suggestions post-process between inside whether to accept or not. It even recommends which type of medication he needs to continue with. For example, for hypertension, it recommends just starting single ACE inhibitor maybe. If the goal care plan goal is not achieved in the outcome 3 months, then it's updated. So even the medication algorithm is embedded into the CDS system. So clinical guidelines, the CDS services, kind of help to have the professional to create the personalized care plan. It's all integrated.
Sounds to me that there's not very much coordination there.
About how the CDS services are created, you mean?
Yeah, I mean in the way that there is already human to look. So the CDS service not some kind of recommendation, and then there should be human who decides
exactly it's like that because it's up to mission about this constant. Actually needs to be to decide whether it's okay or that's is okay. But it's not always black and white. Most of the time the recommendations are gray. So clinician with his medical expertise needs to decide. And in our system, it's possible to reject the recommendation, and the clinician can write an explanation about why he has not followed that guideline recommendation. Because in the end, the ministry also would like to see how the GPs, whether they adhere to the clinical guideline, because it's mentioned on the guideline. How, for example, hypertension patients needs to be managed within the whole country. So it's kind of a wider standardization, but still the GPs are pleased with it or not. They are doctors, not the machine.
Is it sort of similar? Because I know that, for example, with the CDS Cook spec has sort of idea of system actions, which are well suggested resources that you would maybe give another update or whatever. And those have a very similar like way of accepting or rejecting that proposal. It sounds quite similar.
Yeah.
It might have placed there.
Yeah, and in our initial implementation, we're not using that.
Okay.
The explanation that it is embedded in the CDS force response, but later we have integrated as well.
Okay.
In the system we have in Denmark, from the clinical guidelines, you have some algorithms which are doing a calculation based on the individual things you have in the EHR for the patient. So when you open the care plan, there are coming a proposal for the doctors. Here we have done some calculation, and the doctor can just say, I accept those goals. They are okay for me. Then it is recorded also in the database that those individual goals have been approved by the doctor. But the coding system behind is also saying that this was a calculation based on that clinical guideline. But the doctor are also using those goals as a dialogue with the patient and say, impossible. You cannot do all of this at one time. So he's overwriting. Then the data are put into the database with another code that it is set and override by the doctor. So when we are sharing the care plans, they can also see that here has been done some agreement with the doctors and overwriting the clinical guidelines. And I think this is quite important because it is you can't fulfill everything. You can't stop drinking. You can't start doing some more exercise and a lot of different things. If you have diabetes, you have to do a dialogue with the patient and say this is the most important for you the next 6 months. Yes. So what problem does it solve, this care plan? Let me start another place. A few years ago, I was doing a visit to most of the Danish systems in the healthcare sector, hospital, municipalities, GPs. And I asked some of the people I know very well, and they also know their system, and say, please show me in your application, in your EHR system, an example of a care plan. Try to go in and show me the care plan. This is non-existent, at least in Denmark. Do you see that function in your EHR system and from where you are coming?
No ways. Actually, it sounds a little bit awkward, but no way the care plans are most important for nurses, actually.
Okay.
Yeah, but they're during the last 2 years, maybe that's been quite that way implemented. Yeah.
But why do we not have a function which shows the care plan in the EHR system? Because if you talk with friends, relatives, your family who has been in contact with the healthcare system, they say they told me the plan. But when you go to the health system, they cannot show the plan. What I found is that most of the care plans are in discharge letters or in text-based communication.
It's the same in Norway when it comes to the GPs and hospitals.
So the GPs can definitely see that via our system. see the goals, the activities, and
Okay.
when they come back after 3 months, 6 months, they can see whether the goal has been achieved or whether the previously assigned activities has taken place or not. For example, the GP can recommend a referral to a specialist, but it's up to the patient to go to the specialist or not. They can see whether it's happened or not. And also, the specialists can also see the care plan of that patient. We have a national ID system with that national ID, and if the patient then also, of course, the specialist to see his care plan, they can see the care plan as well, because sometimes the treatment needs to continue in secondary care, some is primary care, and they can see the full care plan.
Okay, I think we will skip the last one.
Okay.
Yeah.
And I have a question about the last one.
Okay. Okay.
So when you say static or dynamic, what do you actually mean? You mean the capability of keeping the care plan updated, or you are considering the fact that the care plan could be seen just as a collector of intent of order, or you can see the care plan as a central part of your care provisioning, in which you keep track of also what has been done. So what do you mean exactly here?
It was actually open for you to give some input to this, and you had a number of choices. If you say what has happened until now and what should happen.
And this is the part of, and you can keep maintaining, or you can use and say, this is what I asked to do it. And in the care plan, you keep track of also what has been done. So but it's not the same approach everywhere.
No, it's not the same approach. For example, if you take a new decision from the Danish government, is that they want the GP are still the gatekeeper for the health system in Denmark, but now they also want that the GPs are responsible to follow up and monitor the whole travel around the healthcare sector, which means that now it will be more dynamic. So they are responsible. If you have a patient you need to refer to a hospital, then you need to know the status of what they are doing in your care plans and update it. This is a challenge at the moment. We can do some with our digital level where we are today, but we also have to introduce some new mechanisms so they actually are getting status. For example, if you are sending a referral from the GP to the hospitals to do some examination, you never know if the patient actually shows up there and what was the outcome of this. You don't hear it. But in the future, we have to implement different services, so you have this status in the care plan, and this will be shared among all, so all can see the status of the responsibility. So this here is not only about the digital services; it is also acceptance by the family doctors to accept that now they have this responsibility.
Yeah, but this depends on how the care is organized in each specific jurisdiction.
Yes.
So you may have that rule for the EP, in other contexts we have different rule.
Yes.
I'm just wondering, do you see that there could be any kind of closed loop parts in this system where something happens automatically, like adjusting the dosage of medications? Well, for background, I can tell that we have been running a system here in Finland which automatically adjusts warfarin dosages for the patients in MDR release of our system. And it's been quite widely used there. So we have some experience on that. And what I'm hearing here is more or less that these are kind of open loop systems where there is always a human.
If you take changing in the medication, I think you need a human to come in. I think this is a big decision to say it will be done automatically. But we also have care plans dynamic in that way that you can have a patient which had an update of his diabetes care plan, let us say 6 months ago. But in the meantime, up to today, the patient has been in contact with other diseases. And there they have also made some examinations, blood samples, and so on. And some of those data are relevant for your care plan. So when you are making a view, then it is a view up to date, but not for the goals. But if you have been at a new diagnosis, which are within the scope of the care plan, if you have a new value for your weight, for your blood sugar level, then you can see a graphic that it has evolved since last time. So you are better updated. You are not looking at a view 6 months ago. You are looking what happened today. This is done automatically without any touching anything, but changing activities, prescribing, and so on. I don't think it can be done automatically.
But it can. We have
It can technically, but
also in practice, we have had something like 15,000 patients.
Hmm.
And also there are other things where you can do things automatically, and you just need to correct the risk level and certification according to that risk level.
I think if it should happen, then it should be specified in the clinical guidelines.
It is.
If it is specified in the clinical guidelines, then you can also give some advice to the patient and say, if something happens in that direction, then you should change your medication and so on. Probably this already happens today in specific cases.
Yes.
Is a case decision which could be taken as this, or most of all, maybe algorithms is clear. Just depends on some lab results and medication doses, then it can be automated. But some guideline recommendations are not that clear.
So,
yeah, exactly.
I totally agree. I think in the current crisis in the healthcare, there's a shortage of people working healthcare like that. We shouldn't burden the poor GP with kind of routine decisions that can be automated.
When you say that these changes can be automatic only by probabilistic rules or deterministic rules or both,
I think you need deterministic. I wouldn't use that. I don't know how you would say it.
Okay, let us continue. I can see we are behind schedule now, but we have to talk about. Okay, the next one, why do we need a digital care plan? This slide, what you see here in the blue circle, this is the clinical guideline. What you see in the yellow circle, this is what they do in clinical practice when they are treating a specific diagnosis, for example, diabetes. And what you see in the green is the overlapping zone. And this here is not only theory. You can actually look into an EHR system and see this picture here. So we need a digital care plan so you can be more compliant. Actually, all of those 3 circles should be the same circle. All of this should be green. Should we follow the clinical guidelines? A benefit from a care plan is that you actually can follow up this. You can go to each of the health organization, actually to each of the clinical doctors to see who will follow this. So this is quality in care, or it is monitoring how you're doing your job well.
So I have a comment here. When I have first saw this, I was kind of impressed. Now I think that this is a very limited view. and it misses a lot of innovation that is happening. First of all, first comment, this data can be found in the EHR system. Do you mean the GP system? Do you mean an EHR of a hospital, or do you mean the health system as a whole?
Health system as a whole, it depends on the length
Yeah,
of your
so,
infrastructure.
yeah, so assuming the existence of a data infrastructure that allows you to
Mm.
harvest data from different systems, this would be a health system.
Mm.
The second thing that I see this is a kind of a dated picture is that it doesn't take into account the patient-generated data. So if I have data that I collect with my, high-end watch, I would like this data to be taken into account or be considered, not as at the same level as the health professional, but it goes back to the warfarin example. If something goes wrong, I need to raise an alert.
But-
So that's two comments to maybe improve the slide in the
Yeah.
future.
That's okay. But about your own data to be put in, we are putting own data in, but they are mentioned in the clinical guideline.
Yeah. I didn't say whatever data. I mean data from that contribute to decisions to be made. So maybe we can improve this.
Okay.
And just to comment and follow up on that, I mean that maybe it's to that picture from the IHE computable guideline, file, not taking account the professional of healthcare professional. Doesn't mean that what you are doing outside the guideline is wrong.
Yes.
You can, the clinician can decide for off-label medication. So it's a decision of clinician. So
That's
it's
the yellow part.
yeah, but it's not error. Not necessarily error.
Not necessarily.
But the yellow, this is.
That's a very important point. Yeah, maybe we could change that. It could be
Is it-
not
yeah, we
an
need to
error of
ask.
commission, but a decision or the area of the leeway of the health professional to make a decision. Yeah.
Okay, key data in a care plan. This is what we have in the Danish system. We have more data, but this is the key data. We have a health concern. It could be diabetes type 2. If you have a health concern, diabetes, you are setting up some goals, and they are individual. This is really important. Here you have some examples, and they are actually coming from the clinical guideline, are probably done by an algorithm. To reach the goals, you are setting up some interventions or some actions, and to follow up how is it going. And the observation is actually quite important for the health professionals, but it is also important for the patient himself. They can see, do I follow the goal? Do I go in the opposite direction, or does it work for me?
I have a question here now. Excuse me for that, but I'd like us to kind of go into the fire direction. So the health concern, how is it modeled in fire? I mean, I have an assumption, but I would like to confirm it. Is it like a condition?
It's a condition.
It's a condition. And in Open EHR, it's also a condition. Anybody with Open EHR? We don't know. The goal, I know that there is a resource for goal. Now, interventions and observations, this is something where I kind of am in the wild, because what I understood is that there are activities, there are service requests, and there are tasks, right?
There are more than that. I mean, activity definition.
Yeah,
Then in the part of what you actually do on the other part of the intent, you have medication requests. You can have there are a lot of things that could be intervention.
Yeah.
So this is more like activities, the interventions. Yes, that's what I'm trying to understand where what kind of fire
Medication requests could be anything that could be, but there is no activity resource. Then
a service request, an activity, a task, maybe?
An activity doesn't exist. I mean, you have an activity definition, and then you have a lot of workflow related resources that you can use for that purpose.
Okay. And then the observations is the part of the actual result of an intervention, right?
Yes.
Or Could be also from the patient, right?
Yes.
The observation could be from the patient, could be from a device, or could be from the health system as a result of a service request, right?
From a questionnaire also.
A questionnaire, yeah.
Yeah.
Okay, so maybe we can also do that. We can do one graph here that is this one and another one which maps to resources, yeah?
Yeah, okay.
Can we teach them so maybe intervention should report the intention for this emotion.
We don't have this today, but when the system will grow, then I think it is really important because you can have an intervention which are linked to a specific goal. We cannot see that today, really. Because you can go
The
into
goal is part
to a
50,
data source and say, what interventions do we have for that patient? But you can really not see if it's for a specific health concern or for a specific goal, but this is important.
So the resource, I think, has a goal element there, which can be used in the direction that you are saying. So you
Can be, this is one intervention, the prevention of eyesight injury. And the other patient would be patient was waiting.
Yes,
that's the goal. That's the goal. So maybe what you're saying is that the goal is not one thing, but a collection of things that relate to interventions, right? So you may have multiple goals or hierarchical goals.
yes. And you can also have that some goals are contradiction between different diagnoses. So
Between different care plans, you mean, Morten?
you could have for one disease that you have to lose weight, and for another diagnosis, actually, you have to gain weight. But this is a matter of the practice and for the clinical guidelines.
Okay.
At least from Denmark, we have learned some new concepts which we are using, and I think this is also important for our deliverable here. This is what we call relevant data in a care plan. So if you go into a narrative care plan, most of them are narrative today, we are setting up some tables with relevant data for the different entities in a care plan. So we are putting up here the diagnosis, the health concerns for diabetes. Of course, here for the diagnosis, normally some of those diagnoses are pointing out if you are included and are diabetic. But other diagnoses you need to monitor and take them into account if you are diabetic. You don't see all the codes here. We are also finding in the care plan what medications which can be used for that disease. We also have what vaccinations. We have also laboratory results. This is what we are monitoring today, but it could be other observations. And let me see, the last one is also a catalog of different interventions. And those interventions are normally also an agreement with the healthcare sector, because what can you actually offer? For example, if you have an intervention, say stop smoking, it can be done in different ways. So you have a catalog of interventions which has to be assessed digitally. But this is really important, and this is from those three circles. This is the green one you have to do. So if you are giving a vaccination here for your diabetes, which are not on the list here, then you are in the yellow circle. And then in the clinical guidelines, you also have the algorithms.
I have a question here. You essentially, when you talk about diagnosis, just to connect to the previous slides, this is the health concern, right?
Yes.
or the condition. And you use ICP2. Any thoughts of updating this system, or using, I don't know, SNOMED or something else there?
We have mapping tables, not to SNOMED, but we have a mapping table. If you are having an intervention referring the patients to the hospital, then they are using ICD.
ICD, yeah.
Yeah. So when they are doing further examination and are adding a diagnosis, then the primary care will receive an ICD diagnosis, which are translated into ICPC.
Okay, so
We
this is like
have-
ICD-10, right?
We have in some of our new FHIR standards that we are starting expressing all coded data using SNOMED. What is missing at the moment, because it is a matter who will do the job, it's a lot of work. In my view, in the standard, you should have all possible coding system. So on the top level, you have the SNOMED code, which are the concept for that specific topic you have here, item you have, and then underneath you could put ICPC, ICD. If you leave it up to the companies who are doing their system, then they are looking at a SNOMED CT code, and then they think, okay, this is that data item I have in my system, but this is not the case. Yes.
So, this question, don't have any map process.
Yes, from ICD to ICPC we had.
Yeah, but not process.
No.
We have it in Norway, and I currently working on which on public health institutes. I think you are doing the same with Scotland. That you're somebody's a very good place to start because it's way more computable than the device institute as a group. So what we are using is we're using some CPS, the primary terminology, and then we are machine mapping. So we enrich the data with ICD and ICD and also the modern code system in order to make it more, because it's the same in Norway as in Denmark. The primary care are using ICD2, the hospitals are using ICD, then we use normal signals, walkability was same sort of that. I said semantic moves, so to speak. That's what I've been for. Yeah. We have very good experience with that.
But we had years ago in Denmark some discussion about moving to SNOMED CT.
Yeah.
We couldn't agree because of the Ministry of Finance, because all our payment to the Danish hospital are based on DRG and ICD codes, and for maybe 90%, you could do a mapping. For the rest, it would be so complicated that the Ministry of Finance would say we will not do it because we don't know what happens with the payment afterwards.
Sweden is pretty much like Denmark, but
It's the same. It's the same.
it's the same.
Yes.
Yeah. Same as in Denmark, for Norway, we have a normal city has that. Semantic move.
No, not yet. It's still the same as in the Nordic.
Yeah.
But this is really a challenge which we need to be aware of when we are implementing this, because care plan are cross-sector using different coding systems.
And before you go forward, I would like to ask the connection to the European Health Data Space. Could you comment on that, Giorgio, since you are familiar? These are the coding systems that Denmark is using.
The activity on the part of which coding system to be used is part of the ongoing activity under the network subgroup on semantics. So,
But there is an MVC, right? Does this include?
This is for cross-border, and for MVC, the part of vaccination, you have two ways you can use. You can use the ATC code, or you can indicate the for example the medication, the substance based on SRS.
Okay.
For the part of the diagnosis, they use for the time being ICD-10. Even, I don't know if in the next future they will move to
11.
Nomad,
Yeah.
but for the time being, it will be ICD.
11.
For the time being is ICD 10 that is used for cross-border.
But not SNOMED.
SNOMED is used in many other domain, but not yet for identifying the condition. But there is and still there an ongoing discussion. So I don't know where they will end up.
And what about lab results? It says NPU.
NPU is for the time being is still deploying. There is some push from some northern country to use also NPU.
Mm-hmm.
I know there is an ongoing activity to have NPU map as an extension inside Nomad, but I don't know where these activities
Yes. All the Nordic country, I think, using it.
and Czech Republic.
And Czech Republic.
And what about interventions? This is an internal catalog.
In interventions, the work we are doing, I have 2 slides for
Okay.
this later on, but here we will move to some new authority data sources, and one of them will be interventions.
Okay. Thank you.
And let me see, individual care plans, diagnosis goal, activities, interventions, observations. Do we need to add some more? It can be huge. There are some diagrams for a care plan. What is needed to add here? Do you see that we are missing something? Who are responsible for an intervention, for example? What is the status, the progress? For some care plans, and I think this is what we are working, all of us today, is for chronic diseases. But I think it will also come for other diseases in the future. You don't need to be chronic to have a care plan. Then maybe you should also know the status or the progress. Maybe you should also have some references. For example, in part of our system today, if the system are proposing to change the medication or setting an individual goal, then the user can click and say, why do you think this? And then you have the text from the guidelines. So actually some doctors today see it as a benefit because they are having a kind of, I don't know if it is the right word, but it is a kind of education of the doctors.
I kind of have a comment based on the comment. Remind me your name. Based on your suggestion, I was thinking that in the activities you should have a provenance saying whether this is AI supported or not. So we should probably qualify the activities that are using AI. And the same for observations. Perhaps we need some provenance, whether it comes from the patient themselves or it comes from a health system service. Or
Have this in the system today because you have the author of the value. Yes.
That would be stored source whether it's coming from the patient device or any healthcare professional. If the name of the healthcare professional is part of that. And for the responsibilities for interventions, not in Turkey, but in other new projects, we were directly assigning those activities to not individual healthcare professionals, but like it should be addressed by a nurse or it should be addressed by a specialist. So at this level, we were assigning interventions. And as for references, definitely, as you will see in our presentation, for all guideline-based suggestions, they can see the source, where it's coming from, which page or which guideline.
Yes.
It's really present where it is, what that's suggestion.
I may say we are having, we call it the author for this. This is quite complex also. We can see a lot of errors in the system. If you are changing GP, then all your data are transferred. And those standards which are used, okay, we are testing them, but actually then the author are suddenly this transferring, and suddenly it disappeared that it was that hospital who was putting in the diagnosis and maybe also the date for the diagnosis. It is important to see that you actually had a heart failure 12 years ago, but maybe when you are doing this transfer, maybe it was yesterday. So it is complex what we are doing here. Before it was not a problem because you were just looking at your screen, you could understood all the data when you saw them, and if there was failure, you could say, okay, but now you're taking all the data and putting them into algorithms, and it has to be perfect. Yeah, that.
I suggest to use outcomes instead of observation. First, list, because observation is misleading. Observation is also something happening during the activity, which is not in every case outcome of the activity. And the other suggestion is that after we mentioned the reference, the care plan should have reference. If we want the care plan to work across Europe, care plan should be a document which is self-assessed. So no references. This single care plan should be understandable to consumer without consumer being forced to go and look up for something.
But this can depend on how you are going to exchange things. So if you are bundling everything in the collection bundle, you can provide together with the link already with the resource, even if you are keeping or it's just a way how you decided to share.
I also am not sure about the outcomes versus observations. Observation is a standard way that you would represent the outcome of a lab request. How would that be an outcome? Maybe you are talking on a more general thing about the status of the care plan.
Let me give you things.
Yeah.
So we are treating patient against the pain, and we are giving morphine to the patient. So the outcome of this activity is the pain is less, but there is additional observation. The patient becomes back.
So this is an addition. In addition to observation, you would like to include outcomes, patient reported outcomes, which could be, for instance, the result of a questionnaire.
Maybe I call what they did West. They came up with H7 as well. We could CCDA.
No, but we are at the conceptual level now, Nenad, and the outcome, in my mind, and maybe other people think different, outcome is patient-reported outcome, which is the result of how I feel after I took the morphine for back pain. How do you do it in Turkey? Do you have reported outcomes?
Yes. Higher care plan,
Yeah.
a goal can be linked to an observation, the property called outcome results. So it says that I have set this goal after the activities and dimensions, the outcome is this observation. So it's kind of a link to an observation.
But not to an outcome.
There is no outcome resource. It's a link between the goal and the observation.
Okay.
To the best of my knowledge, but we're checking.
Okay, so maybe Nenad is right in that sense.
Goal.
Okay, we are late. I will move to the third one, and then we can see how we can finalize the future architecture. We don't have a lot of time because I would have liked to show you how we are actually exchanging data today, but we have a very short. We have a national care plan service running. And we have some integrations from the different vendor system, which means that care plans are available for all GP clinics in Denmark, 1,700 clinics. We have been doing some testing, and this integration means that data are flowing both ways. So if you have some data in your system which are needed for the care plan, then they are copied to this care plan service. If you open a care plan in that service and entering new data, then they are also coming back into your system. So if you are, for example, updating a patient's weight, blood sugar, goal for blood sugar, and so on, the data automatically also in your lab system, in the DP EHR system. We are also having screens coming from the care plan module, which are opening in the system. So the user don't know if they are the EHR system from their vendor or from this national module. All data here, including the algorithms. Algorithms are hard-coded. All data are coming into the DP system, and then it is integrated into the care plan module. Our future architecture, we are in the process at the moment. We have described part 1. It is on the high level, and here is actually how it will look in probably in 3-5 years. That we are saying that we have a primary care EHR system, and then we have an integration for what we call relevant data, as you saw. And with the yellow circles here, you can see a number of authoritative data sources. So now we are not taking the data from the EHR system any longer. Most of the circles here, those data sources we already have. We have medication on national level, we have diagnosis, appointments, we have patient-reported outcome, we have vaccinations, and so on. We are missing some of them. But this means if you are with this arrow going up, say relevant data, now you have a filter and say, here I have a patient with diabetes, with COPD, then you can look up what is relevant. Then I can go into our national infrastructure, make a search, and then you get all the data, independent of what hospital, what GP, what municipality. If they are available, you will have all the data. When you have the data, what we are missing today is having some more flexible access to the guidelines. Then we can put with the other arrow all the data, this data set to a computer clinical guideline service in the network, and then you can advise back, and then you can do whatever you want in your DP system. And in principle, this is not only for our DP system, you can use it also in hospitals and other places.
So I have a question. I understand from your discussion that you're using CDA. And in this new system, you will be harvesting the health system at large to collect relevant data, which potentially would update the care plan, right?
Right.
So you will create another CDA then?
We are in this process. What is actually a care plan in the future? Because today, all what we have in the CDA, and also when we are coming to FHIR, we can fill it out, but most of the data are coming from the yellow circles, which means this is not on the slide yet, but I think we will have a new national data source, which are the care plan, which are some few key data, and then this service will point out to other data sources and put it in. We don't need to duplicate those data in the future. Yes?
Yeah, just curious. So this is something you're building on a national level in Denmark now?
Yes. Many of these are already in daily operation.
And when it comes to the layer, the insurance system, we can do reproduce whatever EHR system we like to communicate with these.
Yes.
That's great. We're doing the same with that to help in Norway and the Estonians. So a little smartness and start this from the very beginning. But I think this is way to do it. So
we are for the care plans, we are missing activities or interventions. We don't have it today, it is coming, and we are missing also for goals. In the future, we need to have a national service, because if you have a patient and the doctor are agreeing about setting up some goals in primary care, the patient is coming to the hospital and maybe even to social care in the municipalities. they need to know the goals. And if they are setting up new goals, then the primary care doctor, next time he is updating the care plan, then if the municipality, their system have added their goals and they are within the relevant data, next time the GP are opening his care view on care plan, then he will automatically see the goals set up without doing anything. So we don't need to send a lot of information about this. We will only look the data up in the national infrastructure.
And how frequently are you going to look at it? Have you any thoughts about the frequency of update of the care plan?
Update. We have different rules for the specific.
It's part of the rule.
It is what we call. We have the standards, and we have some integration standard which Medcom are testing. But then we have realized here in the past 3-4 years that we're also setting up business rules. This is rules which are not in the standard and should not be in the standard. For example, for appointments, when we did, we are sharing all appointments for the entire healthcare sector. We found that some vendors were running a batch shop every Sunday night. This is not good. So we are setting up a business rule that maximum 15 minutes after you have done the appointment in your system, it should be published to the national infrastructure, which means many patients, I'm actually doing it myself. If you are having an appointment, I got an appointment for eye examination for next year. When I'm coming out in my car, I'm looking and you see, because I have been making this service, just to see if it works. But it gives sense that you should be able to see that I can't be invited because I have an appointment here. So we have different business rules for the different services, which are also tested. About compute-able clinical guidelines, and this is actually our future. We have on the left a narrative clinical guideline. We need to put it into some computable XML files, some FHIR. And we are also here today and the next days to learn about what others have been doing. We hope we will be able to set up a proof of concept. I don't have a good feeling about how we can do it, but maybe some of you will know. Please tell me. And then hopefully we can set up a national service for this. We have a discussion from some groups and say, don't do this. This is not needed. We can just use AI. And we also have a discussion is this here AI, a part of AI, but what they mean, you don't need to do it. You can just put it into ChatGPT and then ChatGPT will tell you what to do. I don't believe it. I think in some years we need to document what are you actually doing. And we are sharing the care plans. I will not go into detail, it will take too long time, but we have in the middle an XDS infrastructure where we are sharing the information. On the right side, you can see we have access for health professionals via trust. So you have health professionals which are not authorized, but they are working via trust, and then they have access. We have health person, and we have citizens and relatives. And in the lower left corner, you have the GP who are accessing this care plan platform.
So a demonstration for care plans would be the MyDoc app of the Health Professionals Association. Would show the care plan. We have more who can show it. We have a My Doctor app. Oh. We have on Sundhed DK, they also have an app. And then we have our health portal, which are on a web page. So we have 3 national places to see it. And then it is, of course, also up to the hospitals and private sector vendors to ask for permissions to access to the data, and then they can make different kind of applications. And do you have an interface for the citizens to add their data? No, only they can see all data and they can print them in PDF, that's all. They cannot add, so if we are talking about observations like dictated by the care plan, for instance, blood pressure measurements at home, they cannot interact with the care plan in any way.
No, they can only view it.
In the future,
In the future, there is a number of projects coming up, and as you know, also next year, we could think about giving the patient access to their own care plans in the exchange format, which means a file. At the moment, all healthcare professionals have access to all the data without asking the patient. If you have a treatment relation, they can access your data.
yeah, but there is no way that they can update it.
No, it is coming now from this EU directive, but this is notes in your EHR system. This is coming here in this year, but they cannot update. We are still in the process of describing our ambition for care until for the next 5 years, and maybe it will come that they can put it in. But there are some resistance from the healthcare professionals that patients should be able to put more data into.
Do I understand correctly that then where the person would add their observations and maybe patient reported outcomes is the electronic health record system direct?
Yes.
For a bit of timekeeping, let's give the floor to the next session
Yeah.
at 30 past, so 4 more minutes more than.
Yeah. Last one, we have CDAs. I have a link here. I will put it into Sulubi if you're interested in seeing this. I can put a link also to our CDA specification if you want to see it.
Mhm.
This is in English, and we will drop this. Okay? This will
And it would be nice to see how your CDA is
Yeah.
represented in FHIR.
Yeah, exactly. It's a hackathon, so like.
Yeah,
course.
so this is,
I will put this.
yeah, so we would like a couple of examples that we can play with.
And for the next year, you have also to log into.
Yeah, I'm already
Teams.
logged into Teams now.
Okay.
Very nice.
Sorry for taking some of your time. I wanted to understand completely. So
Yeah.
kind of a
Yeah, we can take some that of course if they're very hungry people like me, just.
Okay.
Would it be possible to have a short break or like it's time 7?
Yeah, we'll be taking the lunch break at 12, so 30 minutes still.
Okay, and I just have to leave because I need to check out before be back in 10 minutes.
Yes.
So it will be a mixture of presentation and demonstration. So there are some slides, but I'm gonna skip some of them so that you can see the actual system. See it bypass. More interesting for you. I hope.
Yeah, exactly.
this link.
But this my part.
Presentation. Thank you.
Tell me later what is the focus for today. Hopefully.
Hopefully the whole day.
Also have done nothing.
Okay, we're going to share our experiences in the implementation of personalized care plans based on evidence-based guidelines on top of an HR7 FHIR-based interoperability layer. We can skip the introduction. So I will first of all present to you our previous work on automation of clinical guidelines. It will be short, and then we will walk together with you in the journey from starting from clinical guidelines and how we end up with the care plans. We will start by what do we mean by a care plan, and then I will try to present to you how we are creating a care flow to create a care plan based on evidence-based guidelines, because it's not a single-shot decision support service. We're trying to walk together with the healthcare professionals to analyze the clinical guideline and create a personalized care plan. And we will very briefly present how we extract specifications of clinical decision support services from clinical guidelines, and then how we enable implementation of them in CSOs. And our presentation will also include how we represent the care plan as FHIR, and how do we share the care plan with patients and collect feedback from patients as well, again via FHIR resources. We've been developing such clinical decision support service to enable achievement clinical guidelines since 2006 in a number of EU-supported R&D projects. And until now, we have covered many different diseases, and we have implemented clinical guidelines with different national and international societies. And starting from the City Cloud project around 2016, we have started using HSM-FHIR. Before then, it was HSM-CDA, version 2 messaging. Now all our system is based on FHIR, and all CDA services are CDA SUPs. And very recently, in one of the latest projects, we're also implementing Smart on FHIR. We're building modular smart apps, which can be integrated as a separate module with any EHR system. We indeed demonstrated interoperability with Epic, and we have joined the Connectathon for that. And based on those experiences, we have developed a chronic system, which is integrated care platform for chronic disease management. It is currently being deployed in Turkey, as I will explain to you. It covers, first of all, screening and risk assessment for healthy population for citizens. We can check the risks based on again clinical guidelines, and based on the risk stratification, some of the patients can be diagnosed at an early phase. And for the patients who are already diagnosed, which are already suffering from many different chronic diseases, we're also automating evidence-based medical clinical guidelines for monitoring those patients with chronic conditions. And as you will see, for those patients, we are providing personalized recommendations which are aligned with evidence-based clinical guidelines, and that constitutes the personalized care plan. The system is based on HSM-FHIR, as I have mentioned, so integration with the external system is again achieved by HSM-FHIR. In the core, we have a FHIR repository, it's an open source repository again on our side. I will be presenting some statistics about that as well. And as I have mentioned, care management is for multidisciplinary care activities, not only GPs, it has to involve nurses, the specialists. So we're managing shared care plans among them. So different specialists can work on different parts of the care plan. It's a collaboration, and it also enables transitional care between primary care and secondary care, especially this is quite important in Turkey. The GPs are very well informed when to refer the patients to a specialist, so they can even take appointments, priority appointments for their patients, because it's not always possible to get appointments very easily, but GPs are enabled for that. And the care plans are shared with the patients, so we provide self-management support to patients. In Turkey, our system is not deployed, but in several different EU projects, we have developed systems for that. And we also provide the facility, especially for the GPs, to track their population. They have around 3,000, 4,000 patients, so they can see at what stage their patients, whether they can, which percent of those patients have achieved their clinical goals. Are there any upcoming monitoring or screening episodes that they need to remind the patients? So all are being managed by population tracking. And for the Ministry of Health, it's a step towards value-based care, because they can see, for example, which percent of their patients have achieved their HbA1c goal or blood pressure goal with the treatment that is provided in line with evidence-based guidelines. So the system currently is being used by 35,000 GPs, and including around 30K GP nurses. As Mustafa mentioned, we have around 42 million citizens in Turkey who have at least one care. And as I have mentioned, we have digitized clinical guidelines for screening and monitoring, and the system is tightly integrated with ANAVIS, which is the National EHR system for running CS service, automating clinical guidelines for creating personalized care plans. So this part might be more interesting for you, so I'll be slower here. So we have currently covering screening and monitoring for hypertension, diabetes, cardiovascular risk management, and obesity. So for them, we're also carrying out screenings, but for some other diseases like coronary artery disease, stroke, COPD and asthma, as we provide a service primarily to GP and emergency practitioners, it is monitoring. So when they have been diagnosed elsewhere, the GPs just follow those patients via monitoring flows. So we start with clinical guidelines, and as you see, it is possible to create transitions among different stages. You can start for a patient with cardiovascular risk screening. If the disease is identified as high, we can migrate and move this patient to high-risk monitoring. And when the patient is diagnosed, then he or she becomes a coronary artery disease monitoring patient. So there are transitions among patients as well, among all stages as well. And we start with clinical guidelines. First of all, we create guideline-based care goal automation. We will understand what we mean by a care goal automation. It's a number of pages that follow each other based on conditions and based on the patient's condition. We may present different screens to the healthcare professional based on the condition of the patient. And the objective is to enable the healthcare professional to go through the parts of the clinical guideline to create a personalized care. Okay? We start, for example, by examining the current health status of the patient, and then we move the healthcare professional to a page where he sees and conducts the health examination, like physical examination. Then we check the lab results. Then we see whether he has achieved the goals or not. Then we present the page for him to create the medication plan, the prescription. So you will see some examples. And of course, in each such page, we present the relevant parts of the electronic healthcare records of those that specific patient to the healthcare professional. So it's not a full medical summary. In each page, only the relevant parts that are related with that part of the clinical guideline are being presented. The healthcare professional is able to see them, and for that, of course, we retrieve them from the underlying health information system, national EHR or EHR. And in each page, not in each page, but in some pages, there might be clinical distance support services running behind, like for calculating the risk, or giving advice about medication, dosage suggestions, or personalized clinical goals, like blood pressure goals, or referral suggestions. So those are implemented decision support services. When we retrieve the data coming from the EHR, we test them to do those services via CDS loops, and we retrieve the recommendations that show them in the screen as recommendations, and the GP can accept or not those recommendations, which constitutes the guideline. So in the end, we end up with a care plan with goals, with interventions which are presented as service requests, communication requests, and each such flow is represented as an episode of care, which could include a number of encounters, because one monitoring flow could be done in several encounters. We may ask for a test, and then when the patient comes back, we continue, it is recorded as another encounter. And all of these, as well as some of the file resources like observation conditions that are created during the encounter, are bundled and then saved to the file repository. We will go through all of those steps, so this is just a quick summary. My colleague and I will be presenting each step to you. And I think I have given important statistics about that, but about fire, as I mentioned, in the core, we have a fire repository, and on a daily basis, we have around 220 million fire interactions per day. We have more than 260 million screening and monitoring episodes, and this is impressive. We have more than, I think it's 50 billion, almost, because those statistics were from December, that much of file resources. And the statistics, performance statistics of the file repository are also quite good. As you see, it takes quite less than 3 seconds to carry out fire interactions, fire search. So it's not a running system. So what do we mean by care plans? We have already discussed a bit, so it's similar to what Morten has already presented. We start with health concerns, which could be conditions like diabetes, cardiovascular risk, or that can be a care plan that is focusing on the patient that which is smoking, and we can create a care plan for that. And we set goals. So set the goals to be clinical goals like reducing the HbA1c value below 7% in the upcoming 6 months. Or it could be some goals for the patient like stopping smoking or increasing physical activity. So all of them are presented as goals. And support the realization of those goals, we set activities, interventions like those could be follow-up appointments, starting the medication therapy, or those could be activities for the patient like carrying out 30 minutes per day walking exercise, or it could be a self-measured activity like daily computer measurement. All of them are important as a part of care plan. We start with clinical guidelines, and then what we do, we intend to create a care flow, and we intend to extract clinical support service specifications. So we start with a flow diagram of the care plan. So this is an actual analysis of a clinical guideline from NICE from the UK for blood pressure, hypertension diagnosis. But in the end, it checks several parameters like blood pressure, and based on that, the patient can be either sent home to take self-measurements within 2 or 4 weeks, and then when he comes back, again, we check, we carry out the diagnosis. The patient could be diagnosed with hypertension, or we can say that everything is normal, come back after a year. And we also provide some recommendations about stopping smoking, increasing physical activity. So there are lots of activities here. For example, when we send the patient back home for monitoring blood pressure for the next few weeks, we set aside monitoring activity. We create a follow-up appointment, or we create a diagnosis, or we set a goal for smoking cessation or weight loss goals. So all of those are part of the care plan. What we intend to do is create a user-friendly experience for the health professional to go through this guideline to create those care plan activities. And we will be presenting how we achieve this. So this is only a small part of NICE clinical guideline for hypertension management. If we create a flow chart of actual NICE guideline, it will be a huge flow chart. So we try to create meaningful charts, meaningful pages, to create a care flow for the patient, for the healthcare professional. So the objective is to create a care flow to guide the healthcare professional to follow the recommendations of evidence-based guidelines for creating a personalized care plan. So care flow could be a screening flow or undiagnosed patients, or monitoring flow, or we can have more specific flows. For example, for the GPs, monitoring of coronary artery disease is something different than a specialist flow, which is much more complicated in secondary care. So those are different, and they can be defined in our system. And each care flow is composed of care flow pages we call, and in each page we present the relevant part of patient data from EHRs. It could come from EHR, but it could also come from patient empowerment applications. For example, in Turkey, we have a national EHR system called the Enables, and patients can track their blood pressure, their physical exercises, blood glucose measurements by devices, and they are uploaded to the national system, and we can retrieve them. Or there could be some information collected during the encounter, maybe in the EHR, not everything is recent, maybe during the encounter, the physician can carry out the score assessments with a standardized instrument. And those observations are also stored. And within each page, the healthcare professional may review some risk scores, can review the current care plan section. So in our system, the care plan is dynamic. In each encounter, in each monitoring, we do review what is existing currently in the care plan, And then it is updated. So they review what is already there, the goals, interventions, they check whether the goals has been achieved in the previous 3 months or not, and then update the intervention. So the objective is to create a recent care plan. So this is an example care flow, again from nice clinical guidelines. So just to provide you an idea about how pages are organized. For hypertension diagnosis, for example, we have a screen for hypertension, seeing the history of the patient. What are his previous conditions, what are his comorbidities, we check chemical history there, there's a page for that, and then there's another page when the healthcare professional clicks next, another page where you can collect physical examination data. And based on that, some decisions are taken. So the transition between pages are conditional. You will see that they are defined by a fire test. And if the BP is high, meaning that this is going towards a diagnosis, we ask the physician to ask lab tests for checking possible reasons for the diagnosis of BP. Secondary hypertension, primary hypertension, we need to take some lab results, etc. So it goes when the patient comes back, we carry out cardiovascular risk assessment and then screening diagnosis. So pages follow pages to walk the healthcare professional through the guide. This is my last slide before we see the actual system. This is again just a summary. Care management could be either screening or monitoring. There are different states, and it is there is an accompanying care flow, which is something similar like this, as you see. And these are the pages for history examination, for lab tests, and risk assessments. And we can exit from the flow. All those transitions are conditional, which are defined by file test expressions. And page definitions are again declarative. In each page, we define which patient information we're going to show to the healthcare professionals. So each page definition is composed of sections. Where we can set individualized goals, we can see lab test results, we can see previous medical history as such. And again, the page definitions we are using heavily FHIR, for example, for defining FHIR queries to retrieve the data from the FHIR repository, or for retrieving the input parameters of the CDS services, again from FHIR repository based on FHIR and value sets. And we can even set the visibility criteria of certain sections via FHIR test. For example, if the patient does not have chronic kidney disease, we do not need to show a specific section to see the stages of chronic kidney disease. So it is dynamic. We will see this flow, cardiovascular risk management flow, and we will start with history and examination. And I'm passing the floor to Mustafa. There are slides already here. Please.
Will you share the slides?
Yes, we will share the slides, and there are snapshots in the slides as well, but we thought it's better to see the system live.
And you will share also some data for people to play around with?
Yes, we can. We can share care plans, for example, with clinical care plans.
Okay. So now we will go over the editor part. So Chronic is composed of two main user interfaces. So one side is how the GPs or health professionals, nurses, etc. use the system as logged in authorized users. And the other part is for like the admin definition content creators. So how like Gökçe and I and my colleagues are converting some clinical guidelines first into some structured flows and then implementing them as executable flows. So this is done via this editor. So right now in the system, you can see that there are four disease flows are already configured. Since our time is limited, I will go to the page definition. So as Gökçe mentioned, each flow is composed of several sections, several pages. So usually it flows like first off getting a history of the patient, doing some vitals assessments, and going over the medication history, and then checking some lab tests, and if necessary, repeat some lab tests, and then proceed with some new action planning. So how the patient progressed, how the goals were achieved, setting new goals or some new interventions. So I will show you first very first page of like I have some demo patients here, cardiovascular screening. So this patient is not yet diagnosed with cardiovascular screening. So assume now I'm a GP and this is one of my patients. He's 44 years old. So this is the first medical history page. First of all, we check for some existing diagnosis cardiovascular diseases. So if they are present, normally the system will warn us that this patient shouldn't be in this screening list, so he should move to the monitoring list. So these are normally done by population criteria and eligibility criteria checking. So all those patients are distributed into different lists, but this is like a safe check, another check before proceeding with the flow. And we can see that there are some vitals here that we need to assess. We can see the previous data here coming from the EHR. We always show the source of the data. For example, again, there are some relevant comorbidities relevant for the cardiovascular disease management or some ethnicity which might affect the risk assessment for the cardiovascular disease risk assessment, and some allergy assessment and current medications. Non-relevant medications are here in this case, and some lifestyle risk assessments such as smoking status, etc. So this is how it is visible on the GP side, the health professional. So let's see how it looks like on the editor side. So how do we define this content? So we will play with this vital signs section a bit. So you can see that there is systolic, diastolic weight, height, and body mass index. Let's enter some values like let's 145. So we can see that we immediately got some notification, some warning coming from the clinical guidelines. So it says that if the systolic and diastolic is above 140 or 90, that you should take a second measurement, make sure that it's if necessary measure for a third time, etc. So these are directly some warnings coming from the guideline, and this is actually defined dynamically in the editor. This warning, how it should look like, when it should trigger, they are all defined on the other side. So let's see, enter a few more values like, okay, let's keep our patients like again 71. So right now the BMI is automatically calculated, as you can see. Height doesn't change a lot, of course. And now see the editor side. So I'll go to this CVD medical history page definition. So on the left-hand side, you can see the section. So this is one of the pages. So CVD medical history, as we can see here, this is our title of the page. We can see the same content here. So there is on the left-hand side, you can see the sections. Like each of these is a section in our terminology. So this is a vital signs section. This is ethnicity. This is relevant comorbidities, and the content might differ. And we can see that, yes, there is this diagnosis management at the top. There is this vital sign. The content is defined here. And there is a warning, the vital sign info, you can see here. And the rule is actually defined in this rules part. I will come to that later. But let's play with this content a bit. So now we can see that the systolic, diastolic, blood pressure, etc., they are all defined here. Let's click edit mode. We can see that this is one of a kind of a section. The type of the section is vital signs, but we have several other sections. So these are our building blocks. So in many years that we have been developing such chronic disease management solutions, we have a kind of a library of how to present some clinical data and also some care planning data to the health professionals and how to represent them, how to group them in our user interfaces. So these building blocks have counterparts on both the editor side and also on the manager, so the the GP side. Like when we would like to list of conditions when they were their source, when they were last available in the HR record, etc. We have like a conditions section. But when we want to put a diagnosis among some drop-down lists, then we have some condition selection components. Similarly, with conditions, we have building blocks for family history, for allergies, for immunizations. And for lab tests and vitals, we have the different means of building blocks for that match to observation, prior observations. Like the vital signs, we almost always display them like in this format. So the latest values, up-to-date values should be on the left, but the last three measurements are always visible. And if you want to see more, there is a pop-up here, and you can see the previous history. And so we have these building blocks, and we can dynamically adjust the content. So right now, what we have is a vital signs section, and we can see the elements here. There is the systolic blood pressure, diastolic, etc. And each of them have some configurations, such as the most critical one is the concept. So we always bind these concepts to some clinical concepts which map to terminologies. Like in the case of systolic blood pressure, we can see that it's a line code. We will come to the concepts in a few seconds. And in the case of diagnosis, these can be ICD-10 SNOMED CT codes. I will show you some other examples. Again, in the case of medications, it can be ATC or some local, like in the case of Turkey, we directly use the barcodes of the medications for directly identifying the package. And like that, for encounters, we can limit to the clinic, the exact clinic code, etc. So we bind these concepts here, and for a vital signs, the resource type, this is the file resource type. So which file resource type is being used in this section? It's always observation, but in some other cases, these can be also selectable. And we say that the subtype, in some specific cases, we have some subtypes, such as the most generic one is vital sign, but since body mass index is directly being auto-calculated, so this is a kind of a predefined subtype for us. And the percentiles, similarly, we can bind them to some CDS hook services as well. And units, of course, this is a vital sign. And we can set the minimum and maximum fields, the boundaries for these measurements, which will affect here whenever we come here. We can see the values. But and we have some other conditions, such as this field is required, so it's mandatory to be filled or not. This is also dynamically set, or when it should be visible. So let's add another field, another element here right now. So I click here, and it is now, we have a new element definition. So I will add, as you have seen, the waist circumference is not there. So let's add it right now. We will select among our existing list of concepts. I will show you the definition. And yeah, the unit is automatically assigned. It's coming from the concept definition directly. We can assign some minimum and maximum values. And we can also make it required, so the requirement can be yes and no, and also we can bind it to some conditions, some criteria. But let's do it, make it required itself, but to play with the visibility condition. So in all these fields, we are, this is like a FirePath editor. So just to save time, I wrote it previously. I will directly copy it from here. So I will bind it to the condition that the patient has a BMI value where the value is greater than 25. And we can also, of course, set the unit as well to be more clinically safe. But for the moment, I'll just save this. So whenever there is this requirement is met, we will see that the waist circumference will be asked in the other side. So I'll just save this one right now. It is saved, and I will refresh the page on this part for the GP. So now let's do it again. So let's see this warning as well. 85. So the weight, if we go with 71, we can see that the BMI is less than 25. But if I make it 73, for example, we've seen that, oh, sorry, I didn't enter the translation there. Sorry, it's the name actually. So it's seen with a new element, but normally we should have updated it first. Oh, wastes. So we, of course, support here multiple languages, so multilinguality. So let's save it again. And if I go there, and if I refresh again, yeah, 82. Yeah, let's make it 83. And now we can see that the waist circumference is being asked, and it is mandatory, and we can see the boundaries that we set. So, and on the other part, we also support more features, like it is quite extensible. So we have the query field, which is the most generic field. So we can put further restrictions with the FirePath. So whenever we run this page, actually for the techies who are interested. So whenever we load this page, for example, just a second. I can't access. So the dev site. So if I load this page again, you can see that for each of these pages, several Fire queries are being done. So for example, at the top, we are querying several conditions. So each of them are defined individually, and each of these are queried with different fire queries, like you can see the full query here. This is checking some specific ICD-10 or SONOMED CT code existence. I guess it's for asthma or COPD. I can show it to you like this. So yeah, it's for this patient, and it's the clinical status are being queried here. And this is for querying for the SONOMED CT code and the ICD-10 code at the same time. And now we will see how these are mapped to these concepts on the editor side, and then we will proceed a few pages. So if we go here, the concepts and code management, I've shown you the waist circumference. So this is our concept management page. So go to waist circumference definition here. So we can see that it is this specific lowing code and the waist circumference concept, and we bounded to a one lowing code, but it can be multiple codes as well, especially in the case of conditions, of course. And we can see here that this concept is being used in which pages, in which diseases. It's also visible here. They are totally linked to each other. So if we, for example, come to the conditions and search for type 2 diabetes concept, we can see that it is this ICD-10 code E11 and all of its children. So this is also configured here, whether the code search will be an exact match or a broader search, all of its children, etc. These are also configured here. And these full list of SONOMED CT codes are configured here as well. So automatically, the system, we define the concepts here once, and if necessary, we update them. But this system automatically converts these concepts into some file queries based on this concept definition. And we keep these concept definitions as, again, with another file source. It's kept as a specific type of value set. But of course, we have some other value sets, like shown in the drop-down list, or some multiple checkbox areas, multi-component selection components, for example. If we go here, we can see that we have some asthma trigger factors value sets taken from SONOMED CT. It's a subset of like the pollen, animals, cigarettes, etc. So these are bound to SONOMED CT, and again we have multiple codes here. They are usually shown with some drop downs, etc. in the user interface whenever necessary. So this is how we manage the codes. We also have some editor features for the questionnaire definitions. We used to, I mean, it's not a very complicated resource. You can write it by hand, the questionnaire resource, but we support now an editor feature, so we can easily define the questionnaires with all possible answer options in the system and directly integrate it in the solution. Similarly, we also manage the education materials, which we keep with the file communication request resource in the overall system. And we can link to some URLs, to some specific PDF files, some videos, etc. These are also defined here, can be used in the disease definitions. So let's proceed with just a few pages to show you how the interaction with CDS services, or should I first give the floor to you, John? And also about the timing.
I think it's okay for us to take another 10 minutes.
Fine, then I'll just quickly show. Okay, so let's go here, since we refreshed the page a few times. Okay, so let's enter 67. So I can show you very easily that this is a very simple warning here. So this is, let's see how the rule is for this page. And if I go CVD, medical history part. So there are two types of mechanisms for creating some recommendations, directly goals or other interventions, or just some warnings in the page. Not necessarily part of the care plan, sometimes just some informations like, and also we can set the criticality for these in our system. So, yeah. Yeah, more textual. Yeah. Yeah, and they are more structured. So this is like an info card, and you can see that this is the warning that we have seen here. Then we can see when it was shown. Very easy. Again, we just wrote a simple FirePath query here. Either the systolic blood pressure value 1/140, we have a value for that, value quantity dot value, or the diastolic blood pressure is about 90. So this is just written here and it is being executed and shown in the UI. You don't need to code anything. So we used to do this like that in our first version with the ministry, with the Turkish Ministry of Health. Most of our simple, let's say, rules were triggered directly in the UI code. So we were directly writing them as TypeScript code written in Angular. But it became cumbersome, and we thought that we can do this in a more dynamic manner. And then we came up with this editor and Firebed mechanism. But this is not the only way to do some recommendations. So these are the ones where you can easily, you don't need to develop a CDS hook service for this very simple requirement. So it's quite easy. But in some more complicated cases, we have the integration with the CDS, we have the capability to bind to some CDS services. For example, here we have also a simple one, but it's not very easy to do it in the Firebed. So we have this PECure calculation here below for the smoking status. Let's say our patient is a smoker, and I can also show this to you how it is triggered on the right-hand side. Let's say our patient is smoking both cigarettes and shisha, and then the system automatically asks more questions. For example, how many cigarettes per day? Let's say half a pack, 10 cigarettes. And also how many shisha sessions per week? Let's say 2. And then the age of right now our patient is 44. So let's say this patient is smoking for the last 20 years, half a pack. So it makes 10 pack years automatically. But we can see that this calculation is done not directly on the UI, but it is actually, we can see the CDS hooks request here, and then the response that is created with the cigarette pack years measurement response. So this will be updated when I enter also, sorry, I ruined the UI a bit. And if I enter, let's say, age of shisha is, let's say, for the last 10 years, I forgot the exact calculation formula for that, but it is taken from WHO guideline, one of them. So we can see that this PECure calculation has been achieved thanks to the CDS hooks integration. And we can see, we can easily configure these CDS hooks integrations, again, just by assigning at which input is being gathered. So this needs as input in order to do the calculation, the age at smoking cessation, age at starting smoking, etc. All of these concepts are needed. So this, again, is according to this concept input definition, the front end automatically prepares this bundle, sends to the CDS hook service through REST, and then gets the response and displays it in the UI. So we have similar other such CDS hook services, especially for risk calculation for the atherosclerotic cardiovascular disease risk assessment. But since our time is limited, I will not go into, but if there are any questions.
You are sending the whole patient bundle with all the data.
Not all the data, only this data. So not all the data, because there can be a huge data in the page. For example, in this page, you have seen that all of these lines are almost as another fire query and fire concepts, fire resource.
This now CDS hook is only applied to that smoking concept.
Exactly. We say that we need it, and we bind, of course, the coming response from the CDS hook service to some specific, like this PECure calculation. We bind the output as well. So this PECure, the value of this PECure, it is again another line code, but it is defined as a PECure calculation concept, and we bind the response of this CDS hooks service, which we expect as an observation, and then this is automatically reflected to the calculation, and then it is when we click next, for example, let's see, just okay, I will skip the other parts for now. Yeah, we can say that, as Gökçe mentioned, we are tightly integrated with the EMR underlying EHR system. In the case of Turkey, we are directly integrated with the national EHR solution. So we don't face any issues with, especially for lab tests, the medications. But sometimes some conditions can be missing even in the hospital information systems or the GP system. So they are able to complement these data through here. For example, we have some difficulties in getting family history data from the national system. It's not directly documented in a structured manner. So this can also be complemented here. So we can say that, okay, we have, I know as the GP that my patient has this familial hypercholesterolemia. So this data is when we click next, if I go next, so we can see that in the next transition, there's a body, the fire bundle body. So it's actually a fire transaction bundle. So we can see that the data that is either generated and accepted by the CDS services or entered by the physician, like this diastolic blood pressure, we entered as 85. They are all bundled and sent to the fire repository and saved as clinical in the clinical fire repository. So these pages proceed like that. Since our time is limited, I will not be able to finish. But I can show you just one example, maybe just to, yeah, cardiovascular, exactly. So these we have in the EMR some data for the lab test results, and we can do things like if the creatinine value is available, but the EGFR value is not available, we can automatically calculate them here as well for the non-HDL similarly. So let's proceed. And now we have come to the risk assessment page so for this patient, in this specific example, this uses the American College of Cardiology, the algorithm for atherosclerotic cardiovascular disease risk development. So the optimal 10-year risk was supposed to be 1% since our patient is quite young. But in this specific patient, it's 2.3%. So this is not still high. The patient is supposed to be left in the screening part, so it's not necessarily directly a high-risk patient. So let's proceed, and it is expected that we should set the next episode planning, such as, okay, let's do this we should see this patient in the next 2 years. And then if we go, there is this lifestyle management. So we can see a few more components, such as the goal management. So again, these are all building blocks. This is for the body mass index. This is for the weight. We can see what the previous goal was, whether it was achieved or not based on the recent assessment of the patient, what the next goal should be. This can be automatically suggested by the clinical guidelines and our mechanism, or updated by the health professional if she sees fit. And then we have some further lifestyle recommendations here. As you can see, there is this dietary education material, and there is this patient education material, what you need to know about atherosclerosis. So all of these are also configured through our editor. So again, these are defined, specified with some FirePath queries when to show these recommendations to the patient, such as moderate intensity exercise, referral to a dietitian. Let's quickly see this one in the editor. So I'll go to the page for lifestyle. CVD lifestyle management. And if I go to the rules, we can see that the education and healthy eating referral. So if the patient is overweight or obese, a referral to dietitian is recommended. So this is a structured recommendation. If I click edit, we can see that it's bound to a service request in this case with a referral, and the exact specialist code is represented within the service request. And we can see that the condition for the criteria for showing this recommendation is either the patient has a BMI value over 25 or there is unhealthy dietary habits checked through for this patient. So we can see, and exactly.
Fire path, because it looks into your own fire server and retrieves the data, and you can say if the rule applies or not. What I didn't understand is how you augmented this fire path with the data from CDS books.
The FirePath is actually, we don't directly, so whenever we proceed through these pages, whenever the page is loaded completely, all the data that is defined here, all the clinical data, the weight, height, etc., all of them are retrieved from the Fire server.
Okay,
And now we have them in the front-end UI. So all of whether the patient has, for example, a BMI over 25 or any condition or smoking status, etc., they are at hand as Fire resources. And also the rules are run. These rules are run directly on the UI side, on the front end, with like a JavaScript editor, evaluator, you can think of it.
Okay.
And
everything is FirePath in the
exactly in the front end, everything is FirePath. But whenever FirePath is not kind of capable of writing some complex risk assessment, such as for the ACC-AHA Q-risk2 algorithm, for example. It's not very straightforward. You can write it, of course, but it can be a very huge and messy file path. So we do them in a more, let's say, capable programming environment, such as in .NET or Scala, Java, whatever. I mean, as long as you fit with the CDS hooks REST API interface, you can implement it with anything. And then we can easily bind them to CDS hooks calls, again, through the editor. That's the advantage. But in the end, if you have a complicated CDS service, you somehow need to implement it is the more capable programming language. But we also have some extra capabilities in that respect on the backend side as well. So right now we are much more easily able to implement some CDS hook services compared to the early versions. So yeah, and exactly. And also we can show you how this care plan kind of looks like. So this care plan is composed of the goals and any interventions, etc., that has been accepted by the health professional while going through these pages. It's like a journal. Exactly. Exactly. Yes, this is the care plan. The 5 care plan resource, these two above are goal resources.
Not it's care plan definition or care plan?
No, it's directly a care individualized, assigned to the specific patient named Alp, created by this GP, John. And this is, we can see how it looks like if you like. So if I go to the finalize, I can also add some final notes here. So if we go to the finalize part.
You are not using care plan definitions. You are creating directly the care plan.
Yes.
This page.
Yes, we are not directly using the care plan definition itself.
Based on the recommendations.
And also we are based on, yeah, this is the care plan resource, as you can see. We are the goals, the activities. This is, for example, for the education material, it's a communication request. For exercises assigned to the patient, it says most of the time it's a service request, but we have some specific types, such as the patient order, lab request, or the referral, of course, or the episode planning, the next episode planning. It's also another service request for us. Yes, we have questionnaires. I didn't show them here, but we have the editor capability for the questionnaires as well. Yes. Oh, should we go to which slide, Gökçe? This one?
Yeah.
This one.
So
The overall
you can present.
picture. Oh, you can.
So this is the summary impact. So from the CDS tools, we do retrieve a number of suggestion cards. It can be some treatment lifestyle goals. They could be lab orders, referrals, or patient activities. What do we mean by patient activities? They could be assigning questionnaires for symptom reporting, recommending them some dietary regimens, physical exercises. We can assign questionnaires for patient-reported outcome measures, or we can assign them to carry out some self-measurements like blood pressure measurement, blood glucose measurements. And what else? We can set follow-up appointments. We can assign educational materials, or we can suggest medications as prescriptions. And how do we represent them in the care plan? SS75 care plan, definitely use the goal. For lab orders, referrals, patient activities, we do use service request. Follow-up appointment is presented as an appointment. Educational materials are presented as communication requests, and medication suggestions as medication requests. And we also add the care team because it's not always the GP. Sometimes we also do add specialist staff. So this is the summary.
We don't use inline care plan activities. Yeah. We have a bad experience with them in our first implementations.
We are released for.
Mainly we are released for in Turkey, and in another system in Qatar, for example, we are released for B.
Okay, but it's still you have not, for example, request group or
No. We are using request group while defining let's say the recommendations in the editor side. We are using the request group but we don't directly but we show them, display them to the user, and the user most of the time selects one or two of them, and we convert them into service request or whatever it is, and then we then save them. So we don't group them in the individualized care plan, but in the definition we are using.
All right, time for lunch. I'm sure we have plenty of questions, but once again, this is a hackathon, so the discussion doesn't have to end here. So please pick up your choir stickers so we can get the lunch. Lots of questions, so like that.